Okay, moving on with our second basic discussion on pancreatic cancer. Let's look at the stages of care, if you will, of caring for patients with pancreatic cancer. With any large surgical procedure, and with pancreatic oduodenectomy in particular, I would argue that there's four stages of care, or the four P's of optimal surgical approaches, as I like to refer to them as. Patient selection, preparation of both the patient and the case, performance of the procedure, and postoperative care. Regarding patient selection, age at the top of the list here is certainly a factor, but it should seldom, if ever, in and of itself be a determining factor on whether to operate on a patient or not, as many 80-year-olds, for example, are in better shape than many 60 and 70-year-olds. More important, I believe, are comorbidities, nutritional status, and the patient attitude, as well as their support system. So let's look at each of these a little bit more in depth. Looking specifically at some examples of comorbidities, which are important in the context of pancreatic surgery, patients with hypertension and other cardiovascular issues are at least somewhat elevated risk, as documented in this series of approximately 14,000 Whipple cases, broken down to compare those with medication requiring hypertension versus non-hypertensive patient, with statistically significantly worsened outcomes noted in the hypertensive arm here. In a specific relation to cardiovascular disease, although there's not a lot of data on it, you will encounter patients with symptomatic coronary artery disease concurrent with newly diagnosed pancreatic neoplasms. And in some instances, these patients will require heart catheterizations and intervention, preferably with bare metal stenting, and a delay in surgical resection, or perhaps in some instances a favoring of an interval of neoadjuvant treatment to allow for uninterrupted post-stent platelet inhibition prior to being able to safely proceed with surgical intervention. And again, particularly if you're not planning to do neoadjuvant treatment in these patients, where you really don't want to wait much more than a month on operating, I would typically lean on cardiology to favor bare metal stenting over drug-eluting stents in these cases to help minimize the risk of stent thrombosis after what's going to need to be a significantly abbreviated, shortened interval of uninterrupted platelet inhibition in these patients. But like with everything else we do in medication here, it's a balancing of the pros and cons. In some instances with maybe trivial or more or less symptomatic coronary artery disease, given the significance of the neoplasm, may be best to forge ahead with surgery. In other instances, if you've got a patient who's got significantly symptomatic coronary disease and is at risk for perioperative cardiac events, may be best to get that stenting done preoperatively. But again, you can't let an enormous amount of time go by. And so it's a balance of trying to protect the stents versus letting the neoplasm go too long. And in some instances, that it just may not be feasible to treat the patient. The risk may be so high. But I think in other instances, if you just balance the competing interests and work together in a collegial fashion with your cardiology team, I think we can work through these scenarios, albeit at elevated risk, but in such a fashion that makes sense, co-balancing the patient's concern with neoplasm versus that of their cardiovascular health. Renal failure patients, particularly those requiring dialysis, are difficult to get through such complex procedures. And while it can be done, the risk of bad outcomes are elevated in my experience, and that's been reflected in the literature as well, such as this study, in which chronic kidney injury was associated with prolonged hospitalization, delayed gastric emptying, and pancreatic fistulas after Whipple resections. Such patients will likely tolerate the surgery, provided all goes very well, but they are at increased risk of bad outcomes and even death should even moderate complications develop. So patients that are on the cusp of going on dialysis or on dialysis already, I really have to think long and hard before committing those patients or going forward with pancreatic oduodenectomy on those patients prior to committing them to such a big surgery, I should say. Again, not an absolute contraindication, but most patients on dialysis probably shouldn't undergo pancreatic oduodenectomy. To go back just to the cardiovascular issue for a minute, I think it's worthy to note, as I think all of us realize, an increasing number of patients present with morbid obesity and metabolic syndrome. And not surprisingly, so the several studies have shown that these patients have increased perioperative risk for pancreatic surgery. Another question which comes up is patients with COPD. And patients with COPD requiring pancreatic surgery, at least in my anecdotal experience, tend to tolerate things pretty well as long as they're not on more than 3 liters of nasal cannula in the home setting. And I've typically been able to get these patients through surgery and the postoperative course, although certainly discussions regarding possible tracheostomy need should be had prior to each patient that comes in with significant chronic lung disease. And so COPD doesn't necessarily scare me off unless it's very severe. Hypertension and other coronary artery disease factors, again, I think are things we can typically work through. Chronic renal failure, if it's not on the cusp of dialysis and requiring dialysis, is probably something you can, again, work through carefully. If they're already on dialysis or right on the cusp of it, then I really pause on those patients. So overall, whatever the comorbidities of the patient is, these certainly need to be taken into consideration prior to offering patients operative intervention for pancreatic cancer. However, the context of the patient having very little chance of prolonged survival without operative intervention needs to be considered, and at times warrants pushing the envelope somewhat. The majority of patients, particularly with adenocarcinoma of the pancreatic head, have significant malnutrition at the time of presentation. This is frequently multifactorial in etiology, with obstructive jaundice, pancreatic exocrine insufficiency, nausea, and early satiety often playing a role. Data from the 1990s consistently showed that low albumin and other markers of malnutrition to be independent predictors of poor outcomes with major surgical procedures, particularly those of the magnitude of pancreatic duodenectomy. It's therefore critical that malnutrition be reversed in order or prior to operative intervention whenever possible. And utilization of preoperative nutritional optimization is a large part, I would submit, of the art of pre-operating patients for pancreatic duodenectomy. Less of an issue, again, with distal pancreatectomies, but can sometimes be an issue there as well. Now, this can often be done just simply with oral supplements and concurrent initiation of pancreatic enzymes, but in patients with particularly severe malnutrition, and especially with plans for upfront surgery, or in those patients in whom pancreatitis recurs every time you give them any significant oral intake. At times, I found it helpful to go ahead and place a gastrostomy/jejunostomy tube, a GJ tube, which I favor utilizing personally after most of my pancreatic duodenectomy patients anyway. Go ahead and get that done preoperatively via a laparoendoscopic approach. And that concurrently, I typically do a staging laparoscopy at that time to help further ensure we're not dealing with stage 4 disease. The patients then, once the GJ tube's in position, can receive elemental enteral feedings distal to the stomach, which are less dependent upon patient effort and oral tolerance, and are less likely to induce pancreatitis. Although I have done it, I less frequently utilize nasogastric or nasojejunal feeding tubes. They're certainly less invasive preoperatively, but again, I'm going to use the GJ tube postoperatively anyway, and it ends up saving time, at the time of the Whipple surgery. But the big problem with nasal tubes, whether it's going into the stomach or going into the jejunum, is they're just more difficult to manage in the home setting. They tend to get obstructed more easily, and they're fairly uncomfortable for patients. So we will do that in some instances, but if the patient can't get by with oral supplements in order to deal with their malnutrition, I typically will try to get a GJ tube in, again, in minimally invasive fashion. Go ahead and get the staging laparoscopy done at the same time. If for some reason you can't do that, like I had a lady recently who had a very large hiatal hernia. In her case, I did a laparoscopic J tube preoperatively, or in some other instances, again, we have used nasojejunal or nasogastric tubes. But all other things being equal, if I'm going to require formal enteral nutrition preoperatively, I'll just go ahead and laparoscopically get a GJ tube in, and again, go ahead and get the staging laparoscopy done at that same time. Parenteral nutrition or preoperative TPN, try to avoid it. Only in rare circumstances we use it. But you will encounter occasionally patients who just keep getting pancreatitis, even with post pyloric feedings. And in a few of those instances, I have used preoperative TPN for those patients with cancer-associated pancreatitis that's exacerbated even with post pyloric enteral nutrition. If the patient's being nutritionally optimized with oral or non-elemental feedings, then it's really important also to do pancreatic enzyme replacement, as that's typically necessary in order to offset any exocrine insufficiency. If you're just giving elemental tube feedings, it's not so important. Another advantage, though, even perhaps if you're given elemental tube feedings, is that the enzymes, in addition to helping with absorption, can also help minimize the risk of recurrent pancreatitis, particularly in patients who presented with inflammatory complications secondary to neoplasm-associated ductal obstruction. Now, the majority of patients will respond to doses between 20 and 40,000 lipase units with meals, and in the 10 to 20,000 lipase units range with snack. Just prescribing the enzymes is a little bit of an art in and of itself, secondary to the high copay cost for many patients. And I've kind of found it impossible to keep up with which plan covers which enzyme in the most economical fashion. And some of this is perhaps by design, a moving target, I don't know. But I typically warn patients that the copay on the enzymes may be excessive. And if this is the case, to have the pharmacy reach out to me so that we can figure out a financially reasonable option for the patient. In instances in which the patients, again, are completely relying on elemental enteral nutrition, there's really not as much utility to pancreatic enzyme replacement, except for possible suppression of pancreatitis in patients that are having issues with that. One of the most common additional presentations of pancreatic head masses is obstructive jaundice, and this frequently contributes to nutritional compromise in the patient. It also can lead to coagulopathy and immunosuppression, such that severely jaundiced patients typically benefit preoperatively from biliary decompression. For more moderately jaundiced or mildly jaundiced patients, the data is less clear, and we'll review that shortly. But in patients with moderate or severe protein calorie malnutrition who are also jaundiced, it's difficult to optimize these patients typically nutritionally without addressing the jaundice. Additionally, although more commonly seen with biliary obstruction secondary to choledochal lithiasis, cholangitis is a potential concern in these patients and provides another indication for consideration of preoperative biliary drainage. Less life-threatening, but just as significant to many patients, is the severe urticaria, the severe itching that many jaundiced patients suffer from. And it's not uncommon for these patients to present with oozing from multiple cutaneous scratching sites. While these are all arguments for preoperative biliary drainage, these drainage procedures, it's important to recognize, can be associated with complications. And arguably, the best study comparing patients undergoing preoperative biliary drainage before pancreatic duodenectomy versus those not having drainage preoperatively was a multi-center randomized prospective trial conducted in the Netherlands and published in the New England Journal of Medicine in 2010. And the data, or the most pertinent data from that, is presented here, which, as you can see, in comparing early surgery with no preoperative drainage with those patients who undergo ERCP or other preoperative drainage, and you can see that there was no statistically significant difference in relation to mortality, and there was actually a statistically significant increased complication rate in those patients undergoing preoperative drainage. In other words, statistically less morbidity in the upfront surgical patients. And so while many of our gastroenterology colleagues will likely disagree, I believe it must be recognized based on this and other data that biliary drainage shouldn't be regarded as an absolute necessity preoperatively in jaundiced patients undergoing pancreatic duodenectomy. So it's not mandatory that all patients moving forward with pancreatic duodenectomy who are jaundiced undergo preoperative biliary drainage. Having said that, There are instances in which I think it really makes sense and really should be regarded as near a standard of care. Certainly, patients that have cholangitis, there's no question those patients need preoperative biliary drainage, get the infectious issues from the cholangitis dealt with decompression. Also, though, those patients which have significant malnutrition and therefore need a significant period of optimization, or other reasons for patients requiring significant time intervals between the diagnosis of pancreatic cancer and operative intervention, primarily, for example, those patients receiving neoadjuvant treatment, or those who require more than just a short interval of preoperative prehabilitation, if you will. Additionally, at times, logistically, these cases are difficult to get on, and you hate to say it, but frankly, in some instances, just because of logistical purposes, it's necessary that the patients undergo palliation of the jaundice preoperatively with usually ERCP stenting, although we will talk about other options as well. And let's actually move on and just talk about that right now as far as how to perform the biliary stenting. And once the decision has been made to proceed with biliary decompression, the next question is how to go about it. The typical options in our institution are either ERCP or PTHC, percutaneous transhepatic cholangiography. Some institutions are also utilizing, it should be mentioned for completeness sake, endoscopic ultrasound directed biliary decompression, but as our GI group has not yet embraced this, we'll not discuss that option today. ERCP is overall the preferred approach in the absence of contraindications, as it's associated with an overall lower complication rate and can be readily done concurrent with a diagnostic endoscopic ultrasound. One example of the data supportive of this is this paper published in the in the Surgical Endoscopy Journal in 2015. And in this study, we see that ERCP as compared to PTHC, the patients overall had an increased survival and they also had a decreased complication rate. And so ERCP overall better than ERCP overall better than PTHC here in regards to overall survival. Your note, however, this group, which is actually the group that had no preoperative intervention, so that although ERCP did do better than PTHC, the group that actually did the best in this group was those not requiring preoperative biliary drainage, arguing that as this is uncontrolled data, the need for biliary drainage overall and concurrently the need potentially for utilization of PTHC rather than the typically favored ERCP is likely a marker for worse disease presentation. So a lot of this literature favoring ERCP over PTHC, there may be some confounding bias as it's in the instances, particularly when it's uncontrolled data, as the majority of these studies are. Overall, though, again, there are a number of advantages to the ERCP. There's no external drain afterwards, as there is with PTHC. Numerous studies have shown less incidence of bleeding complications. And again, the ERCP can typically be done with what's now the diagnostic modality of choice for pancreatic head neoplasms and tail neoplasms for that matter, endoscopic ultrasound. So ERCP has the advantages of no external drain, less bleeding, other complications, some studies which associate with overall decreased mortality, and the fact that it can be done concurrent with EUS. Disadvantages of ERCP, though, there is about a 3 to 5%, even in the best of hands, incidence of pancreatitis, which can be at times severe and life-threatening. Additionally, the presence of duodenal diverticuli and duodenal narrowing can make ERCP technically challenging and even non-feasible in some cases. In instances where ERCP is not a good option, PTHC or percutaneous transhepatic cholangiography is a good backup option for biliary decompression, particularly in an institution like ours where we're blessed to have a cadre of very talented and collegial interventional radiologists. Now, these can be difficult procedures and may require several sessions with an initial simple decompression, such as pictured here in the middle schema, with access to the duodenum through the ampulla, subsequently being obtained with a pigtail type of catheter at a different session, 24 to maybe 72 hours down the road. So on particularly difficult cases, they may just get in, get the biliary system decompressed with a simple drain like this, and then subsequently go and place the internal external transampullary stent again through the liver. So it's transhepatic, but going, then ultimately through the ampulla into the duodenum, where it can function as an internal external stent at a subsequent date. In most instances, however, at least here at Mount Carmel, the IR team is able to go ahead and place these at a single setting if they can get through the area of the ampulla. But in some instances, the obstruction and the biliary dilatation is so severe they have to do it at a subsequent setting. Whether at the initial setting or with a subsequent setting, once a transampullary catheter is in place, you initially leave it to external drainage. And you can see what this looks like radiographically here. Now, typically, I try to get these capped off prior to the patient being discharged from the hospital, as otherwise the biliary losses have a significant tendency to be associated with dehydration and electrolyte abnormalities. You really don't want to discharge patients home with these PTHC catheters to external drainage. You want to try to get them capped off within several days and then get them home. If for some reason they're not tolerating the thing being capped off, then you probably need to have them reshoot another cholangiogram, and potentially the catheter needs to be changed because it may be obstructed or it may need to be upsized. And in most instances, if you're trying to prehabilitate these patients prior to surgery, then you would ideally like to have them capped off. In some instances, if it's just not feasible, that patient probably needs to go home with a PICC line and plan to get interval IV fluids either in the home setting or to be coming into the infusion center several times a week in order to prevent the electrolyte and fluid losses which occur otherwise. At times, it's significant to note that bleeding can occur along the drain tract, and this must be observed for both in the short interval and on a long interval basis. I should just go back to this slide. I'm sorry to see where it's coming out. Certainly, bleeding can occur along the liver, and that can just happen if there's not quite a large enough catheter in there to tamponade it initially. And that's somewhat concerning, but can usually be, if it is significant, addressed with just an upsize in the catheter. The ones that are really more concerning is the ones that occur after the PTHC's been in for a week or two, as those are more suggestive of a pseudoaneurysm, and these typically warrant an emergent CTA and possible angioembolization. And so it's important that, once these patients are drained and they're back on the floor, to observe them carefully for any evidence of bleeding. And then it's also important that the patient, as they go home, their family, the patient themselves, any other caregivers in the home setting, or if they're going to an extended care facility, that those providers caring for the patient recognize that, hey, if there's blood coming through this catheter or around this catheter, that's a potentially life-threatening situation. They need to come emergently to the emergency department and notify me while they're on their way, because this can be just as life-threatening as the post-pancreatectomy visceral pseudoaneurysms are, and those are a big deal. Now, while an advantage of a PTHC catheter is that it maintains access to the biliary tree, a big downside, even once they're capped off, is the discomfort it causes many patients, as well as the greater risk of biliary colonization, which occurs as a result of an ongoing tract from the external environment into the biliary tree. For many patients undergoing neoadjuvant treatment, facing a significant delay prior to operative intervention and some degree of immunosuppression related to the chemotherapy, I therefore often favor a subsequent transition from the PTHC catheter to a wall stent. This can be done with a purely transhepatic approach, or in some instances it's preferred to do a combined endoscopic and radiologic rendezvous procedure. But typically our interventional radiologists can do this, purely transhepatically. But once you remove that catheter, number one, you've lost access to the biliary system, and certainly you can regain it, but it may be more difficult as the system is now no longer dilated. But also, as you pull that catheter out, you lose some tamponade along the tract, and you may have bleeding. That's why most interventional radiologists will tend to leave the tract in for a week or so, so that I should say they leave the catheter in for a week or so that a tract has had a chance to develop. And in some instances, embolization coils, as was utilized in this case, or other measures may be utilized along the tract to help minimize the risk of bleeding. For completeness sake here, I do just want to mention in relation to PTHC catheters that while PTHC tends to be second line to ERCP for periambulary biliary obstructions, it's often the more optimal approach for proximal biliary obstructions, such as Klatskin tumors or perihilar cholangiocarcinomas, due to the better proximal drainage the transhepatic approach often delivers, as well as the guidance these catheters can provide at the time of proximal biliary reconstruction. So for the most part, periambulary biliary obstructions, ERCP is the best way to non-operatively decompress those in most instances in the absence of contraindications. But for periambulary, I beg your pardon, but for perihilar issues, such as Klatskin tumors, you're usually better off with a PTHC in my experience as first line. Okay, let's spend a few moments looking specifically at types of stents. The initial stents used with ERCP were plastic stents, such as pictured here on the left. And these still, I believe, have a role for short-term biliary decompression, but they do have the significant downside that they tend to become occluded in most instances after several months. Not all instances. I had one patient who had extremely severe pancreatitis and severe SIRS and multiple complications, ended up being in and out of the hospital for like a year, and we limped his biliary stent along for because he had significant stenosis after it was in later on. We limped that thing along for almost a year, but that's the exception. Usually these plastic stents will become occluded after several months, and so they're not a great long-term palliation issue. They're more of a short-term fix. And so patients needing decompression on a longer-term basis, it's really preferred that a wall stent be placed, whether it be patients receiving neoadjuvant treatment, and so it's going to be several months before they come to surgery after their initial diagnosis with malignant biliary obstruction, or certainly in those patients who are non-resectable and are going to require stenting as a long-term palliative measure. These benefit clearly from wall stenting. And one example of the literature on this is this meta-analysis published in Gastrointestinal Endoscopy, where you can see the predominance of the literature favors the self-expanding metal stents or the wall stents, as highlighted here in the red, which pretty much all outcomes in all regards being better here as compared to plastic stents in the green here. And just to summarize this article, or the conclusion of this article, they recommended that self-expanding metal stents should be considered as the first option in malignant biliary obstruction, and they looked at both hilar and distal malignant obstructions. We're specifically looking at distal here. But the reason is because they have better patency, a lower occlusion rate, less need for intervention, and fewer overall adverse events than plastic stents. And they make recommendations at that point that guidelines should be essentially changed to reflect that back when this was published back a number of years ago now in 2015. And so for patients that are just need a bridge of several weeks to get prehabilitation and then go to surgery, plastic stents are fine in that setting. But for your patients who are going to receive several months of neoadjuvant treatment, or patients who require long-term palliation, then wall stenting is better than the plastic stents. This begs the question, though, what type of wall stent? Because there's bare metal wall biliary stents, there are covered metal stents, and now there are partially covered metal stents. Which one's the best? Well, it depends on the situation. For patients with fairly low sites of biliary stenosis and with no issue taking the bile duct well proximal to where the stent will need to lie, I believe it's typically optimal just to have a non-covered stent placed, as you'll simply cut the bile duct at the time of surgery above the stent, and it'll come out with a specimen. By using a bare metal stent, it likely decreases the obstructive issues which can sometimes develop with covered stents, such as cholecystitis and pancreatitis, which again can occur due to obstruction of the cystic duct or pancreatic duct, respectively, with covered stents. On the other hand, the uncovered stents become fairly incorporated within the wall of the bile duct, and they can be difficult to remove if they lie over the bile duct, which needs to be preserved or anastomosed. In instances in which the likely level of anastomosis needs to be covered preoperatively, and you need to have some of that more proximal bile duct stented for whatever reason, it's therefore better off probably to use a covered stent, which can be easily removed. They slide out a lot easier. They don't incorporate, and so they're not as stuck to the wall, and so you can remove them intraoperatively without the significant tissue trauma that otherwise will occur with an uncovered stent. So as long as they can put the stent in pretty much just in the periampullary level, and I can easily take the bile duct without making an unnecessarily complex proximal biliary anastomosis at the time of surgery, as long as I can just transect that bile duct well above the stent, and I'll typically ask that the gastroenterologist favor putting an uncovered stent in. Whereas if for whatever reason, from a technical standpoint or because of how the tumor is, they're going to need to go more proximal, and some of that bile duct, which is going to need to be covered with the stent, will need to be preserved. In those instances, I favored a covered stent. In regards to patency, uncovered stents are more likely to become obstructed when left in long-term due to tumor ingrowth, and are therefore potentially less favorable in patients who are being palliated long-term and without evidence or without plans for resection. Covered stents suffer less ingrowth, as you can see here in this study, which we'll talk about in a moment. And they also have the advantage of being able to be changed endoscopically. So once you put an uncovered wall stent in, you're kind of set. Now you can go in and you can do a stent within a stent, or you can do clean out techniques. But if you have, and you're putting these in by ERCP, the same is not true transhepatically, because you can't pull a transhepatically placed wall stent back out through the liver, obviously. But you can, by ERCP, pull one back out transampullary-wise. And so if you have a covered stent in and it becomes obstructed, as they can more due to sludge at times, then you can just pull that stent out over a wire and put another one in. And so covered stents suffer less ingrowth and have the advantage of being able to be changed endoscopically, but they do have the disadvantage at times of obstructing things, in particular being notorious for causing cholecystitis if they cover the cystic duct. And another downside of the covered stents is that they're more prone to sludge buildup. This article here in the Scandinavian Journal of Gastroenterology kind of highlighted these differences, where uncovered stents, again, higher risk of tumor ingrowth, covered stents, higher risk of sludge. So there are definitely pros and cons, but if it's going to be a patient that's going to potentially have prolonged survival and need prolonged stenting, then maybe you would favor having an uncovered stent. Whereas as somebody who, yes, you can't operate them, but their life expectancy is 6, 7, 8 months at most, then it's probably best to just put a covered wall stent in, because when the sludge associated obstruction occurs, it tends to occur quicker than the tumor ingrowth obstruction does. Another downside, which is worthy of mention, of covered stents is the greater risk of migration and development of malposition. A number of years ago, when performing a pancreatic duodenectomy on a patient who had a covered stent in place while receiving neoadjuvant therapy, I neglected to note at the time of surgery that the stent wasn't included in the resection specimen, and ultimately it turned out to be in the distal small bowel, and by the time we recognized this, he was more than a week out from surgery, and going back, to the operating room was just not a good option. So we ended up just leaving it there. Unfortunately, it never caused him a problem, but it did certainly cause me a bit of significant sleep. Here's a patient specimen from another pancreatic duodenectomy. We'll actually talk about this case during our last discussion as a case example, but I've opened this on the back table just to check the specimen, and you can see how the fully covered stent with the good response to neoadjuvant treatment is kind of the hold on the wall of the bile duct of the stent has loosened and the stent has migrated significantly into the duodenum. So this is an issue as well. Many gastroenterologists are now utilizing partially covered stents, as they may offer kind of the best of both worlds, with the covered mid aspect preventing much adherence and ingrowth, while the ends, which are bare metal, minimize the risk of displacement. These hypothetical advantages were borne out in an Italian study published earlier this year on gastrointestinal endoscopy, with a statistically significant improvement in time to recurrent biliary obstruction being noted with the partially covered stents here at basically a year, as compared to 238 days with the fully covered stents. You'll also note that the risk of migration was less with the partially covered stents as compared to the fully covered stents. There was a slight, as you would expect, increased risk of ingrowth issues with the partially covered stents. But so there may be advantages to these partially covered stents, it would appear, in regards to kind of the best of both worlds between the fully covered and the fully uncovered stents. I would like to just emphasize for a moment again the risk of acute cholecystitis as a significant potential downside when a covered stent's placed over the cystic duct. While the majority of the time you'll get away with it, when you don't, it can result in severe cholecystitis. And I've actually had several patients present septic from this in the preoperative period prior to undergoing pancreatic duodenectomy, but after the initial diagnosis. Just a very brief case example, and again, this is the patient we just looked at the picture from, and we'll hear more on this patient during the next podcast. But this was a 53-year-old male. He came in with a borderline resectable pancreatic adenocarcinoma with obstructive jaundice. At the time of his EUS, he also underwent an ERCP with covered biliary stenting on an outpatient basis. Initially did well in the home setting, but after approximately 12 hours, he developed right upper quadrant pain and nausea, prompting return to the emergency department, where he was found to have a significant leukocytosis, right upper quadrant tenderness, and Murphy's sign. So kind of a classic presentation consistent with acute cholecystitis. Cross-sectional imaging was obtained, which demonstrated appropriate stent positioning, because that's the other thing you have to worry about is stent malpositioning or perforation after these cases. So, you have to confirm the diagnosis, and we did so with cross-sectional imaging, which showed the stents in the right location, but the patient's got a significantly thickened gallbladder and a lot of acute inflammatory changes with severe pericholecystic fluid here, consistent with acute cholecystitis. Fortunately, in this instance, the patient responded to percutaneous cholecystostomy and an interval of antibiotics, which I believe is the optimal way to manage these situations. But it was kind of a hassle as the guy, is dealing with this percutaneous tube now while he's undergoing subsequent neoadjuvant treatment. I had another patient who we were trying to tune up just for several weeks, wasn't getting neoadjuvant treatment. We were just trying to tune them up nutritionally and do prehabilitation for several weeks prior to upfront pancreatic duodenectomy for resectable pancreatic cancer. Covered stent had been placed to help with the process. In retrospect, I probably just should have had him place a plastic stent, but in any case, he got a covered stent, resulted in severe cholecystitis, which then progressed to the point of gangrenous cholecystitis. Got a cholecystostomy tube, but because of the gangrenous changes, it actually became displaced due again to the extended gangrenous changes. So we had to take the patient emergently to the operating room for worsening sepsis with lack of source control. As I was unable to perform the procedure laparoscopically, I'm looking at our options there. We got the open cholecystectomy done, and then I just conferred with anesthesia, and I had a preoperative discussion with both the patient and them about this as well, as if I could do it laparoscopically, fine and good. We'll give the patient some more time, just to recover and things. But if you're in there with an open surgery, that was going to be a significant time interval to when it would be safe to go back in there. And I did not think, as long as the patient was stable, that was in his best interest. So we actually went forward with the Whipple, as I thought that the suboptimal situation of going through chronically inflamed tissue at a subsequent surgery in a short interval versus a very prolonged delay in surgery being addressed. And we just went ahead and proceeded with the Whipple at that point. Fortunately, the patient did okay, but after this case, I became a lot more adamant about having input regarding the level at which these biliary stents are being placed, and to some degree, the type of biliary stent which is placed. If I'm going to operate the patient in a few weeks, a plastic stent's just fine. You don't need to do a wall stent. If you are going to do a wall stent, if it's going to be covered, really try to avoid that cystic duct and then try to stay below it if at all possible. If not, then we have to kind of think about other options and be able to plan accordingly. So in regards to preoperative preparation, nutritional optimization and jaundice palliation are often major factors. I believe it's also important for patients to be as active as possible leading up to surgery, and I strongly encourage them to be both physically and mentally active. We really want to have them keep up with whatever level of cardio fitness is at all possible for them to have. I don't want them to go home in between the time of diagnosis, perhaps, which is increasingly made in the inpatient setting in this day and age, and just lay around for a couple weeks as we perhaps prepare to move forward with surgery, or for that matter, neoadjuvant treatment. I mean, as much as their bodies will allow them, being active, exercising, I think is vitally important, as it helps not just physically, but also emotionally. Speaking of emotional and spiritual issues, I think these are very important as well. And I try to figure out what sources of support the patients have, and if they have any spiritual aspects of their life, and encourage them to lean on these sources of strength and support as they face the emotional and physical stress that pancreatic surgery entails, particularly when it's being performed for malignancy. I'm hesitant to proceed with any major surgery, and particularly with a pancreatic oduodenectomy, if I get the sense that a patient has inadequate support and or emotional fortitude. I think it's important too that patients are able to come in the hospital at the time of these big surgery and not be distracted by a lot of other concerns. That's not always feasible, but in as positive a fashion as possible, I try to ensure that patients have their affairs in order, such that they can solely focus on recovering from surgery and overcoming the difficult disease process with which they're afflicted. I will often approach families, and sometimes with the patient, sometimes without them, and just clarify with them that, hey, if you want to say something to mom or dad, whoever it is, whatever the relationship is, now may be the time. And you got to be careful in how you do that. You don't, want to, scare people. But I think at the same time, there are times when patients don't do well, and families regret not having that window of time to maybe say things which were left unsaid, for example. So try to just make sure that that work's been kind of done. Those affairs have been addressed preoperatively. A number of years ago, I was caring for a relatively young patient who had been estranged from her parents for a number of years. They lived down in Kentucky, as I recall. We delayed her surgery actually a week to allow her to travel out of state to reconcile with them. We had an initial date scheduled. I kind of got to talking to her about this, and I said, listen, you need to have things right with mom and dad before you go into this big surgery. It was inconvenient, but we delayed the surgery for a week. She took some time to travel out of state to be with them and reconcile. And at one of her post-operative visits, she later told me that from her perspective, this was the single most important preoperative step, or really most important step, in helping her get through the surgery. So taking into account those things that I think all too often we as surgeons maybe don't engage enough with, the emotional and spiritual aspects of our patients. In regards to more immediate preoperative preparation, a noteworthy trial was published in JAMA last year, which I like for several reasons, probably the most significant of which is that it confirms a longtime bias of mine that cephalosporins are not adequate perioperative antibiotic coverage for pancreatic oduodenectomy cases. This has at times put me at odds with the infectious disease team and perioperative protocols, but it just never made sense to me to utilize an antibiotic that does not have enterococcus coverage prior to a major biliary procedure, when enterococcus is a fairly common biliary pathogen. This was a very well conducted trial with no pharmaceutical money, furthermore, to muddy the waters and potentially lead to questionable results. So I think this is a really noteworthy study. It was multi-center, randomized, prospective, with 967 open pancreatic oduodenectomy patients who received either pip/tazobactam, i.e. Zosyn, or cephalexin as perioperative antibiotics. Variables such as preoperative biliary stenting that could impact upon infectious complications were well considered, and the two groups were appropriately comparable, with specifically 483 randomized to Zosyn, 484 randomized to cefoxitin. You can see a few fell out along the way as documented here, but overall very comparable numbers here in which to compare. And overall, the pip/tazobactam group had a lower incidence of surgical site infection, including deep infection in a statistically significant fashion relative to the cephalexin group. Or the cefoxitin group. I misspoke there. I apologize. The cefoxitin group is actually mefoxin or cefoxitin that they were comparing it to. I misspoke earlier when I said cephalexin. I apologize. So PIP, tazobactam versus cefoxitin. Again, lower incidence of infections with PIP tazobactam compared to cefoxitin in a statistically significant fashion. Furthermore, though, a number of other postoperative parameters were improved in the Zosyn group as compared to cefoxitin, including probably most significantly the pancreatic fistula rate, which you can see was very statistically significantly different at 12.7% versus 19% in the tazobactam versus the cefoxitin group. Additionally, the need for additional percutaneous drain placements was lower with Zosyn, as was the overall incidence of postoperative sepsis. Interestingly, the C. diff incidence was also lower due to arguably the Zosyn group, despite the Zosyn group arguably having a broader spectrum, and you would think maybe would increase the risk of C. diff. So C. diff was also lower in the PIP tazobactam group. Now, in looking at why would the pancreatic fistula rate and the need for drains be reduced? I mean, potentially some of it related to the infections, but it's interesting to note that Enterococcus is a collagenase forming organism, which has been associated in other studies with anastomotic leaks. And so it kind of makes sense when you recognize that Enterococcus can be collagenase forming, which can predispose to pancreatic fistula rates due to leaks. And so not only did PIP tazobactam significantly decrease the risk of infectious complications, but it also decreased the risk of pancreatic fistula rates, need for percutaneous drain placements, incidence of sepsis, and the incidence of C. diff colitis. So the well-supported conclusion of this well-conducted study was that perioperative use of PIP tazobactam should be considered the standard of care in patients undergoing open pancreatic duodenectomy. Now, does that extrapolate to robotic pancreatic duodenectomy? Does that extrapolate to distal pancreatectomies? I personally think probably so, at least in the minimally invasive Whipples, maybe not in the distal pancreatectomies where you don't have the biliary tree involved. But I personally, whether it's minimally invasive or whether it's open, I think Zosyn is the appropriate preoperative antibiotic, perioperative antibiotic in the absence of contraindications. So I wasn't really sure where to slip that in, but I think that's a noteworthy paper. So I wanted to kind of include that here as we kind of move toward the tail end of preparation review of patients for pancreatic duodenectomy. Another significant aspect of patient selection is determination of resectability and preoperative staging, as it doesn't matter how well you prepare the patient. If they have advanced disease at the time of presentation, they're not going to do very well with operative intervention, at least not in the long run. I'm not going to spend a lot of time on this, but suffice it to say that in my estimation, all of these patients that are undergoing workups for pancreatic cancer need, in addition to a good thorough clinical exam, a 3-phase CT scan of the chest, abdomen, and pelvis to assess for distant metastatic disease and local extension. And CT has advantages, I believe, in regards to other modalities, in regards to overall staging, local regional extension, vascular invasion, as well as evaluation of distant metastatic disease and resectability. Now, for reasons we mentioned in the first discussion, the majority of patients also benefit from undergoing endoscopic ultrasonography in order to secure the diagnosis. In some instances, EUS also provides additional data regarding local lymph nodes and the relationship to vascular structures of the tumor, as well as the relationship to other local structures. But in most instances, this is better assessed with CT scan and more reliably assessed with CT scan. MRI can at times be helpful, typically in sorting out liver metastasis, but is otherwise pretty significantly hampered by motion issues at vascular interfaces which prevent it from being as helpful as CT scan. You just can't get a good assessment of whether or not there is local abutment or encasement of vessels with MRI because there's almost always at least a little bit of motion artifact and because of the effects of the duodenal air adjacent to the area that you're concerned about. So MRI pretty much reserved for evaluation of whether or not there is liver metastatic disease. Certainly in biliary, neoplasms, MRCP has a much more significantly helpful role. PET CTs, everybody, primary care physicians love to get PET CTs. There's this, I think, in the community, too much of a thought process that if something doesn't show up on PET, then there's no cancer there, and you can rule out cancer with a PET scan. And we see those scans misused like this on a weekly basis. And really, in relation to pancreatic cancer, there's no true benefit from routine use of PET CT in the setting of pancreatic cancer, with the exception of evaluation of questionable metastatic disease. Most commonly, this is an issue in regards to pulmonary nodules. The problem is that most of the time it seems like the pulmonary nodules are too small to really even be well characterized on PET scanning anyway. So it's not real common that we'll utilize PET CT in the preoperative workup, although in isolated instances it can help in regards to evaluation for distant metastatic disease. But for the most part, the workhorse of preoperative evaluation, in addition to your clinical evaluation of pancreatic cancer, three-phase CT and EUS. Let's take just a minute to review the current staging of pancreatic cancer. T1 tumors are those less than 2 centimeters, broken down to less than 0.5 centimeters, greater than a half, but less than 1 centimeter, and 1 to 2 centimeters for 1A, 1B, and 1C, respectively. T2 tumors are those between 2 and 4 centimeters, whereas T3 are greater than 4 centimeters. T4 tumors are specifically those that invade arteries or significant arterial invasion of named adjacent arteries. In 0 disease, obviously no regional lymph nodes are involved. In 1 disease is 1 to 3 lymph nodes, and in 2 disease is greater than 3 lymph nodes involved. Overall staging then, stage 1 is T1 or T2 in 0 or lymph node negative tumors. So lymph node negative tumors, which are under 4 centimeters, equates to stage 1 disease, which we don't see very often, unfortunately. Stage 2 disease is T3 in 0 in regards to stage 2A. Much more commonly seen as stage 2B, which involves anything which doesn't grow into arteries size-wise with lymph node positivity under 4 lymph nodes. If you have more than 4 lymph nodes involved, that bumps it up to stage 3. Or if you have a T4 tumor, regardless of lymph node status, that's stage 3. And obviously, stage 4 disease is any metastatic disease. Well, with pancreatic cancer being as aggressive as it is, the vast majority of patients that I see in my practice are either stage 2B or stage 3. That we bring to surgery. All too many of them present with more advanced stages that we're not able to operate on. But as far as operated pancreatic duodenectomies in particular, typically end up being a stage 2B or stage 3, as it's pretty unusual to see lymph node negative disease. In addition to the local lymph nodes, from a metastatic standpoint, the most commonly involved areas are the liver, lung, and peritoneal surfaces. And it's certainly important that these be diagnosed preoperatively, as resection typically offers no survival benefit in the setting of metastatic disease. There are, however, exceptions to most rules, and the gentleman pictured to my left here is an unusual case. He underwent in-block distal pancreatic splenectomy for a stage 2B pancreatic adenocarcinoma, after which he underwent adjuvant treatment. He did well for 5 years and then represented with oligometastatic disease to the liver. A thorough evaluation at that time demonstrated no other evidence of spread, and the patient had an extremely good performance status. Recognizing that he had a better than typical phenotypic cancer, his medical oncologist felt that we should consider partial hepatectomy, which, after some initial hesitation, very significant hesitation, I did proceed with. The patient did well and continues to do well 3 years out. So I just think at times we have to be careful about being dogmatic and recognize that there are intercase variabilities which need to be considered at times. Having said that, this is kind of the exception that proves the rule. And in over 25 years of taking care of pancreatic cancer patients, this is the only time that I've knowingly operated for a resection of metastatic disease. And in the vast majority of instances, stage 4 disease equals no resection indicated. In keeping with this, it's important to recognize that approximately 15% of patients who have negative staging on cross-sectional imaging will actually have small peritoneal or hepatic capsular metastasis, not appreciated on even good cross-sectional imaging. So prior to proceeding with pancreatic duodenectomy, and in some instances even distal pancreatectomy, but particularly prior to Whipple's, I will typically perform a brief staging laparoscopy, either preoperatively, which is my preference, or on the day of surgery. Doing it on the day of surgery does have the advantage of saving the patient an anesthetic. It has a significant disadvantage of messing up the OR schedule or losing a lot of OR time, which has otherwise been devoted to a significant oncologic procedure. So typically preoperatively, or in some instances on the day of surgery, we'll do a brief staging laparoscopy with the goal of preventing a 15% unnecessary laparotomy rate in patients that might have these small areas of metastatic disease not picked up on the preoperative cross-sectional imaging. This is most likely to be helpful in patients that have larger primaries, that have higher CA19-9 levels, or have the questionable presence of ascites. As we've said previously, if a patient is significantly malnourished, I will often perform this at the time of gastrostomy and / jejunostomy placement, at the time of GJ2 placement, if the patient's going to benefit from an interval of enteral nutrition. Instances when we're considering neoadjuvant treatment, I will perform this concurrent with the patient's port placement. You go ahead then with the port placement regardless of what you find, because they're typically going to get, if not preoperative neoadjuvant therapy, then at least a palliative chemotherapy, if they've made it to that point in consideration for surgery. Now, I do want to emphasize these are not extensive or elaborate laparoscopies of some have endorsed in the past. We're not looking in the lesser sac. We're not doing a big extensive mobilization of anything, because really the only areas of concern that are missed with any regularity with cross-sectional imaging is the lining of the peritoneal cavity and superficially on the liver. So we just need to see the liver capsule. We just need to be able to scan the parietal peritoneal surfaces and the visceral peritoneal surfaces to some degree of the abdomen. So these are really the areas to focus on, in addition to performing peritoneal washings, as has been shown to be helpful recently. In some instances, keep in mind, I had a patient not too long ago, last month, that did a Whipple on it, had a previous trauma laparotomy and an open abdomen. I'm not doing a staging laparoscopy in that setting. If the patient's had prior significant open abdominal surgery and is likely to or has documented significant adhesions, then we'll push the envelope for this, and we may either omit it altogether or certainly be quick to bail out if significant adhesions are encountered. Just as important as assessing for metastatic disease is evaluating the extent of local invasion of pancreatic tumors preoperatively. The choice of this, or the choice study for this, as has previously been noted, is triple phase contrast enhanced abdominal CT. But understanding what to look for on the cross-sectional imaging, as well as what to be aware of when you're out in the operating room, requires, of course, a good understanding of the peripancreatic anatomy, and in particular, the local vascular structures adjacent to the pancreas. As the majority of operative cases involve the pancreatic head or right-sided pancreatic resections, the most common structures of concern are typically the portal vein, the superior mesenteric vein, the superior mesenteric artery, and the common hepatic artery. in less common instances. But basically, we're concerned about the portal and the superior mesenteric veins, the superior mesenteric artery, and the hepatic arteries, the proper hepatic and the common hepatic arteries, as those can impact on the preoperative staging and the intraoperative conduct of the case. The inferior vena cava and the left renal vein also are in the area and can occasionally be invaded, but I just haven't seen that occur with much regularity. So those are certainly a concern to keep in mind as well, but much less so than the mesenteric vessels and the hepatic vessels. And we're going to talk extensively about issues related to vascular invasion of these structures during the third podcast as we address borderline resectable and locally advanced right-sided pancreatic cancer. Prior to that, however, let's take several minutes to discuss local invasion concerns commonly seen with left-sided pancreatic tumors or distal pancreatic lesions. From a vascular standpoint, these typically involve the celiac trunk when there's vascular involvement, and at times the common hepatic artery as it comes off of the celiac artery. Now, the splenic vessels, the splenic artery and the splenic vein, are obviously the most commonly encased with left-sided pancreatic cancers, and you see that very frequently, but this does not constitute locally advanced disease, as these will both be included in the en-bloc resection along with the spleen. And, splenic preservation with a distal pancreatectomy, in the setting of benign disease, fine, although you still have concerns with a fairly high splenic infarction and abscess rate, at least historically. I think that's becoming less so as we increasingly get more comfortable and have better ways to visualize the vessels and take them selectively with minimally invasive approaches. But if you're dealing with a pancreatic adenocarcinoma, spleen needs to come out. I'm sorry. I don't think there's a place for preserving the spleen there. This is life and death stuff. You need a good en-bloc resection, getting all those lymph nodes out, getting the splenic vessels out widely along with the spleen, and this is no case for splenic preservation. But so the splenic vessels frequently encased, but not a big deal in regards to preoperative staging. Now, if you've got splenic vein thrombosis and secondary varices, this can, however, make the resection significantly more difficult and potentially bloody, though, and you've got to take that into account during both your preoperative planning and in relation to your intraoperative conduct. For example, just last week, I had a lady who had a neuroendocrine tumor of the distal pancreas, which was encroaching upon and obstructing and thrombosing the splenic vein, and she had a good number of varices. So, for example, when we're taking down the short gastric vessels, there's no way I'm relying on an energy device for the most part in that setting. Those are being taken down with a stapling device and liberal use of clips. And you just really need to treat those varices with a lot of respect, or you will have significant issues with intraoperative and, in some instances, postoperative bleeding. So, splenic vein thrombosis leading to varices can be a significant deal in regards to safely performing the distal pancreatectomy, but encasement of the splenic vessels does not constitute locally advanced disease because it's going to come out with the resection. In addition to the local vessels, there's also frequent involvement of the stomach seen with distal pancreatic adenocarcinomas, and in some instances the transverse colon, certainly, as these are in the area as well. And at times these will require en-bloc resection to facilitate R0 status being obtained. So just to review, local invasion concerns with right-sided tumors requiring a pancreatic duodenectomy. You have to be concerned about the portal vein, superior mesenteric artery, proper hepatic artery, common hepatic artery, and less frequently the IVC and the left renal vein. With left-sided or distal pancreatic tumors, the celiac artery, the common hepatic artery, and also the stomach and the colon are the most common local invasion concerns that you will come across. Let's look now at a difficult case of mine from almost 20 years ago, which I think illustrates some of the issues which can arise with locally advanced distal pancreatic neoplasms. Now, Now, this case is significantly atypical for our current era, or would be really not seen in our current era, in that it predates neoadjuvant treatment as an option. Until the mid 2000s, we didn't have really neoadjuvant protocols that were an option, and so this is wasn't a consideration in this case. So the case is atypical for our current era, and that it predates neoadjuvant treatment as an option. It's also unusual in that it involves a patient who presented with an acute infectious complication precluding delay in his operation. So this is not a common case. Nonetheless, I do think it's helpful to illustrate some of the issues which can develop with local invasion of these left-sided tumors. The patient was a previously healthy 57-year-old who 5 months prior to presentation had noted the onset of left-sided dull abdominal pain. He had undergone an outpatient workup by his primary care physician, which was a bit atypical even for the time, in that it was limited to an upper GI and a small bowel follow-through, both of which were unremarkable. He was subsequently started on proton pump inhibition and had some improvement of his symptoms, which led to him not following up for some time. Months later, however, the pain had returned and worsened, as well as having become associated with early satiety and weight loss. Eventually, with the worsening pain and development of weight loss, and what really the patient was starting to consider seeking treatment finally, but what pushed him over the edge was he became significantly short of breath, and ultimately he presented to the emergency department. Upon evaluation in the emergency department at that time, the patient really had a fairly unimpressive physical exam, with the exception of some fullness in his left upper quadrant and tenderness to deep palpation. Digital rectal exam demonstrated evidence of heme-positive stool, while laboratory evaluation demonstrated an iron deficiency anemia, a mildly elevated alkaline phosphatase, and hypokalemia. Much more impressive was cross-sectional imaging, which demonstrated a malignant appearing mass of the distal pancreas with local invasion of the colon. You can see the narrow colon here, kind of a string sign there. The stomach. And there was also noted to be evidence of splenic infarction. So you've got this large pancreatic mass with gastric involvement, colonic involvement, and significant involvement of the splenic vessels to the point of showing evidence of significant splenic infarction. The mesenteric vessels were free. You can see a fat plane here between the area of the tumor and the mesenteric vessels. And on other cuts, you could see that it approached the celiac axis, but did not appear to invade the celiac axis. Ominously, the CA19-9 in this non-obstructed patient was greater than 13,000. So just specifically, again, looking at the local invasion, gastric and colon invasion, as we said, encasement of the splenic vessels, obviously, and abutment of the celiac trunk, mesenteric vessels were free, significantly elevated CA19-9. Again, this is not a patient in this day and age I would even consider for surgery without a significant interval of neoadjuvant treatment, but we didn't have that available back then. And additionally, as we'll see, this patient develops infectious issues, which ultimately takes us to the OR in and of themselves. The patient underwent an upper endoscopy, which revealed evidence of neoplastic changes along the greater curvature, biopsies of which returned as consistent with adenocarcinoma. A concurrently performed colonoscopy demonstrated extrinsic narrowing of the distal transverse colon without obvious mucosal involvement, but with inability to pass the scope proximally. A CT scan of the chest was obtained and demonstrated indeterminate 3 to 4 millimeter nodules bilaterally, along with evidence of segmental pulmonary emboli. The patient therefore subsequently had an IVC filter placed. Over the next several days, he experienced worsening abdominal pain and melena, and subsequently developed several episodes of hematemesis. He was transfused with several units of PAC cells, but remained persistently anemic despite transfusion. He also developed increasing left upper quadrant pain and fevers worrisome for infectious complications. Given the persistence of bleeding, as well as evolving colonic obstruction, along with what appeared to be ischemic changes with secondary infection in the spleen involving, it was felt that there was really only two viable options. And again, this was pre-neoadjuvant chemotherapy being utilized for pancreatic cancer, at least at our institution at that time. It came soon thereafter, but the two options at this point were felt to be, palliative care with hospice or aggressive upfront surgical exploration and attempted resection. Given the patient's age and previous good performance status, he elected for surgery and was scheduled for the OR for exploration the day after his IVC filter was placed. The evening before surgery, the patient developed an increasingly septic picture with soft pressures, oliguria, and fevers. He was started on broad-spectrum antibiotics, or we had him on antibiotics, but we further broadened his antibiotics, added some antifungal coverage, and significantly fluid resuscitated him, and he responded pretty well to this. So not having really other options other than just purely palliation, which he wasn't interested in, we pressed on with surgery as scheduled the following day. At the time of laparotomy, we immediately noted the spleen to be infarcted and foul-smelling, consistent with gangrenous changes. Something I've only seen one other time in my career is the spleen will typically tolerate infarction without secondary infection. But I grew up on the farm, and literally this spleen was akin to a pile of cow manure. I mean, that's how severely infected and infarcted it was. Cultures of blood and from the necrotic spleen ultimately grew out Clostridium septicum, which, as you'll recall from our necrotizing soft tissue infection discussion, is an organism like strep bovis that, when present, suggests an underlying neoplasm. We move forward at the time of surgery with an en-bloc distal pancreatectomy, splenectomy, segmental colectomy, and partial gastrectomy. The tumor extended, as expected from the cross-sectional imaging, up to the celiac trunk, but we were able to dissect it off of the celiac artery. The most difficult part of the case was actually freeing up the gastric involvement of the tumor without having to perform a total gastrectomy, as there was significant invasion high up on the greater curvature of the stomach. And we essentially had to perform, this is the stomach that you see here, left lobe of the liver, here's what's left of the stomach. We essentially kind of did a modified gastric sleeve with a somewhat tenuous suture closure, which had issues with leakage postoperatively, unfortunately. In retrospect, I might have been better just doing a total gastrectomy, but I was trying to avoid having to do an esophageal jejunal anastomosis. But with the significant problems we had with this gastric tubularization postoperatively, I probably would have been better off just going up and doing that. With this somewhat formidable surgical procedure, we were able to obtain R0 resection. A J-tube was placed at the time of surgery because obviously there wasn't enough stomach left to put a G-tube in, so we put a J-tube in, we did a colostomy. Here's the specimen. You can see the pancreas here, significant portion of the stomach, the infarcted and grossly infected spleen, and then the segment of colon. The patient was able to be extubated on postoperative day 1. As we've said, the blood cultures grew out Clostridium septicum, and we continued broad-spectrum antibiotics for a significant interval of time. But not unexpectedly, he had a difficult postoperative course requiring nearly a month of hospitalization, but he was ultimately discharged to the home setting. Unfortunately, during follow-up cross-sectional imaging, prior to consideration of any adjuvant treatment, the pulmonary nodules were found to have increased in size and were subsequently shown to represent metastatic disease. Around this same time, he kind of developed failure to thrive and ultimately was not felt to be a candidate for additional treatment, and he ultimately passed away 8 months postoperatively of metastatic disease. While an extreme example, I wanted to share this case because I believe it highlights a number of issues that can be seen in instances of left-sided pancreatic cancers which have locally advanced. Such cases may require significant dissection along the celiac axis, as well as en-bloc resection of the stomach and/or colon. The spleen, again, I would argue, should always be resected in instances of distal pancreatic adenocarcinoma, along with the splenic vessels as the benefits of splenic preservation are far outweighed by the likelihood of leaving disease behind with attempts to preserve the spleen. Now, as we'll emphasize in the next podcast, such extensive en-bloc resections are typically only performed nowadays after a patient has demonstrated response to neoadjuvant chemotherapy. But to return to this case, really the only break we got was that the celiac trunk itself was not encased. In instances in which you're not that lucky, I don't know if I'd call us lucky on this patient, but in that regard we were lucky, but in instances you will encounter pancreatic cancers of the left side that do have significant celiac involvement, and in such instances it's helpful to sometimes perform what's called a modified Appleby procedure, as this can be helpful in achieving R0 status in patients who have demonstrated a response to neoadjuvant chemotherapy but have significant involvement of the celiac axis from a left-sided pancreatic adenocarcinoma. The original this is the modified Appleby, but the original Appleby procedure, we should mention, was described in the 1950s for locally advanced gastric cancer and included a total gastrectomy. A modified form without routine gastrectomy was repurposed in the early 1970s and then again repopularized somewhat in the early 2000s for locally advanced pancreatic cancer. And what is the modified Appleby procedure? Well, essentially it's confirming that the patient has a patent gastroduodenal artery, which is supplying adequate blood flow to the hepatic arteries, and then essentially transecting the celiac axis along with the common hepatic artery proximal to the gastroduodenal artery. Again, it's necessary that the patient has to have good flow through the gastroduodenal artery here, which is going to be preserved because that's where your blood flow is going to come postoperatively through the pancreaticoduodenals, such that the superior mesenteric artery system can provide through the pancreaticoduodenals and through the gastroduodenal artery perfusion to the right and left hepatic artery and therefore provide liver viability. But it won't work if you've got an inadequate or a thrombosed or encased and involved gastroduodenal artery. You have to have good flow through the gastroduodenal. It also doesn't work well in instances in which some of the hepatic arterial flow comes off proximal to the GDA, specifically a left gastric origin of the left hepatic artery, because you're going to have a high risk of left hepatic infarction if you take the celiac trunk in that instance. But as long as you have kind of a conventional, if you will, left hepatic arterial anatomy and the GDA is patent, then the celiac trunk may be resected in block with the cancer here, and you can have perfusion to the liver maintained through the gastroduodenal artery. In such instances, it's prudent certainly to place a bulldog clamp on the GDA in order to ensure I beg your pardon, not on the GDA. It's prudent to place a bulldog clamp on the common hepatic artery to ensure that you have adequate good flow through the GDA and that you continue to have good palpable or at least Doppler flow through the hepatic arteries. So before doing an Appleby or modified Appleby procedure, number one, make sure you got good flow through the GDA. Number two, you've got your common hepatic artery and your celiac trunk dissected out there. Just put a bulldog clamp on that proximal to the GDA takeoff and make sure that you've got good perfusion or adequate maintained perfusion through the hepatic arterial system. And then you can proceed with resection of the celiac trunk and the common hepatic artery along with the tumor if that's necessary in order to obtain an R0 resection. Okay, so having touched upon some of the issues related to locally invasive left-sided pancreatic neoplasms, we'll stop at this point and we'll plan to discuss borderline resectable and locally advanced right-sided pancreatic cancers during the next discussion.